Then we can start.
Okay. Shall I, Kunal?
Yes, sir.
Okay. So, good evening, friends. I am Dr. Bankim Desai, along with my co-chair, Dr. Dhaval Tanna. Welcome you to this virtual meet. This is a second in series of immunoallergy conclave brought to you under the aegis of Rheumatology Association, Gujarat. Today's topic is systemic approach to the diagnosis and management of chronic pruritus. Some of the issues in medicine always gives headache to find a cause and then manage them. As you know, when neurologist starts getting headache to find a cause of chronic headache, orthopedicians for chronic back pain. Similarly, about the chronic pruritus. My wife being a dermatologist, who is also a joint probably, when she starts scratching her head, I know it's likely going to be chronic pruritus. There are established causes, I guess, related to endocrine, metabolic, hematological, drugs, psychological, etc. But still, we feel helpless in treating them. To tell us more, we have with us this evening Professor Manuel Pedro Pereira from Portugal, currently working in Germany. Dr. Pereira, who is just 38 years old, but has very illustrious career in the field of immunology and allergy. Currently, he is consultant dermatologist, researcher, and certified investigator at the Institute of Immunology and Allergy at the Charité University of Berlin, Germany. Dr. Manuel Pereira has done his medical school at the University of Porto, Portugal. I love that place, sir, where I visited about 5 years back. He did his PhD from University of Copenhagen in Denmark, and also a doctor of habilitation. Uh, he has uh, he has his to his credit about more than 110 publication in peer reviewed journal. Co-author in about nine index nine I mean 9 book chapters, I guess, and he has about more than 1,600 citations. Dr. Pereira heads many posts at his institute. Most noteworthy are the head of the Pruritus Outpatient Clinic, division head, real-world researcher, lecturer, and principal supervisor for medical students at Berlin, and associate editor for the Frontiers in Medicine. He has received several grants awards like European Prurigo Project, Young Researcher Award by German Pain Society. So friends, Dr. Manuel has an enviable and remarkable achievement in his field at his young age. I request participants to write questions in the chat box. We have 40 minutes lecture and then about 15 minutes of question and answer. So with this, I request Dr. Manuel Pereira to begin his talk. Thank you.
Thank you very much for this introduction to the topic and to my person. It's a pleasure for me to be here. I'm also very thankful for this invitation and to be able to talk about chronic itch. These are my financial disclosures. And I would like to start with the clinical presentation of chronic itch. So how does a patient with chronic itch look like? And I brought you this clinical picture of a patient with chronic itch. Itch is a subjective symptom, so you cannot really see it, but you can see the consequences of itch. So you can imagine how much this patient suffers due to their itch, that he scratches his back so badly that he damages the skin so much to have a bit of relief from the itching that he's suffering. And you see also fresh lesions with excoriations, but you also see old lesions, so the scars. So you can imagine that this is going also for a very long period of time. And although you do not see itch, you can see the suffering through the scars and the skin lesions that patients induce themselves due to scratching. And I would like to start with a definition of itch. Itch is defined as an unpleasant sensation in the skin that provokes the desire to scratch. And we categorize itch in acute and chronic. Acute itch is physiological, so it has a protective function. So if you have an itch because an insect is crawling on your skin, then the itch is important so that you can remove this aggressor from your skin, so it has a protective function. But when itch or pruritus stays for 6 weeks or longer, it's considered chronic. So and chronic itch is a symptom of diseases, so it needs to be diagnosed, so what the cause may be, and also it needs to be treated. So it's not like the acute itch where you just wait until it's gone. If the acute itch becomes chronic, then you need to do a diagnostic workup and you need to treat these patients. And chronic itch is quite prevalent, is actually a very frequent problem, much more frequent than people think. So the lifetime prevalence is about 1/5, meaning that 1/5 of the population will have chronic itch sometime in their lives. And we see that chronic itch can affect everyone, so all genders, all age groups, all ethnicities, but we see a higher prevalence in older age and maybe also a slightly higher prevalence in females than in males. And it's a condition that is associated with a very high impairment of quality of life. And there are many diseases that are associated with high impairment of quality of life and also with itch. So chronic itch is also seen in eczema, in infectious skin conditions, and these are also conditions that are associated with a high impairment of quality of life. To understand chronic itch, there is a clinical classification based on the presentation of the patients. And to understand this classification, I brought to you a few clinical cases. And I will start with a very simple clinical case of a 4-year-old child with itch since the age of 1. And mostly the face is affected, the extremities are affected, especially the flexor surfaces, as you can see here in this clinical photo. And due to the itch, of course, the sleep is impaired. And you see here that the skin is inflamed. So this is a classical case of eczema, so of atopic dermatitis. And this is also the first category of the clinical classification of chronic itch. Patients that have itch due to a skin condition, usually an inflammatory skin condition like atopic dermatitis, but also urticaria, psoriasis, cavius, also T-cell lymphoma. These are all dermatological conditions that have chronic itch as a hallmark symptom. And so this is the first category of the clinical classification of chronic itch. Now, a second case of a 63-year-old female patient. She has a generalized itch for 2 years, very severe from the intensity, and she has a known liver disease, a primary biliary cholangitis, for many years now. And you see also in the lab work that the liver values are pathological, so bilirubin is enhanced, and also the other liver parameters are increased. And this is then the cause of itch. So she has a cholestasis that is causing the itch. And this brings us to the second group of patients with chronic itch. These are patients with chronic itch on non-lesional skin. So they have no skin condition. They are not dermatological patients, but they have chronic itch either due to systemic condition like liver disease, or for instance, also commonly renal insufficiency, especially if patients are on dialysis. Certain tumors like lymphomas can also cause chronic itch. Drugs can also cause chronic itch on normal appearing skin. Then there is a smaller group of patients with neuropathic itch conditions. And these are patients, for instance, with a small fiber neuropathy. That's a common complication of diabetes. So diabetic patients often have pain, but also itch. Another neuropathic condition that leads to itch are compression syndrome. So if a nerve is compressed, it might cause not only pain, but also itch. And we also have patients with a somatoform of itch, which is an exclusion diagnosis. But these are all patients that have normal appearing skin. And then we have another group of patients, and here is an example. This is a 46-year-old male patient with itch for 6 months, and you can see that especially the trunk is affected, and he scratches, and he has these lesions that you can see on the skin. So he has these nodules that are excoriated, and the itch itself is also very, very high. And he's a dialysis patient, so likely the itch comes from the renal insufficiency. But because he has this chronic scratch lesions, he comes into the third group of patients with chronic scratch lesions. And these are patients with prurigo, as you can see in the photo, or also patients with lichen simplex. Lichen simplex is different than prurigo. Usually these are solitary lesions, usually affecting the lower limbs, and they occur also due to chronic manipulation of the skin. So patients with prurigo and lichen simplex, they develop these chronic lesions due to scratching and manipulation of the skin, but the underlying cause for the itch itself can be of various nature. So at the beginning of the itch disease, either patients have itch on inflamed skin, like in atopic dermatitis, for instance, or they have itch on non-lesional skin. And predisposed patients, if they scratch, they may develop these chronic scratch lesions, and then they belong to this third group. And often these patients are more complicated to treat and to diagnose, because just looking at the skin, you cannot really tell how it began, if it began on normal appearing skin or if it began due to a skin condition. And even if you ask the patients, they might not really know how it was at the beginning, because often they have this condition for several years and they cannot really remember how the skin looked like when the itch started. So this is the clinical classification of itch, and there is also an etiological classification. And here you see the different possible etiologies for chronic itch. Of course, you have skin conditions that can cause chronic itch. You have systemic conditions, as we have discussed, also neurological conditions that may cause itch. Psychiatric or psychosomatic conditions may also be a cause for itch. And then we have an important group of patients with multifactorial itch. And these are patients that have several conditions that may cause itch, and you cannot really say from which one the itch is coming. For instance, older patients that have, for instance, renal insufficiency and also an atopic dermatitis. So these two factors may contribute to their itch, and therefore you will classify them as having a multifactorial itch. And in some cases, even though you do the diagnostic workup, you cannot really find a cause for the itch, and these are then classified as having chronic pruritus of unknown origin, which is also a condition that is quite common and also difficult to treat. But what is common in all patients with chronic itch is the high burden of disease. So these patients, they often develop mental disorders like anxiety and depression. They often cannot sleep. So there is many studies showing that there is a correlation between the intensity of the itch and the impairment of sleep. And because they cannot sleep, they cannot really function. So they have loss of productivity at work. They cannot do their normal daily activities. They often perceive also skin pain, so not just itch, but also skin pain. If you ask a patient how the skin feels like, they will often tell you that they also have stinging and burning. So these are all pain characteristics. But overall, there is a high burden of disease, a high impairment of quality of life, and this is common to all causes of chronic itch. So we now move to the diagnostics of chronic itch. And there are some guidelines that you can consult in order to also to read about the diagnostic that is recommended in chronic itch, and also about the treatment. And there is a European guideline which was just published a few weeks ago, so it's very new, and you can consult them. It's open access, so you have the reference here. There is also a German guideline which is also available in English, and it's from the end of last year. So it was, so the original guideline was from 22, but it was just updated at the end of last year. And they are very similar, the guidelines, because many of the authors are the same. So you can consult here in order to see what diagnostic workup is recommended in detail, and also about the treatment. And there are also specific guidelines for prurigo. So for these patients with chronic scratch lesions, there is one international guideline from 2020, which is being updated now and will be probably published next year, the new version. And there is also a paper from the US with expert recommendations for the diagnostic workup and treatment of patients with prurigo. And here, to understand the workup, I brought you a difficult clinical case, so that you can see that diagnostic workup can be complicated in this patient, population. And here it's the case of a 3-year-old female patient with periumbilical itch. So she just had itch around the in the abdomen, and she had no skin alterations. The skin looked normal, but the child would scratch the area, and she would also lay down on the cold floor because that alleviates the itch. But otherwise, she was healthy. So it was not really known where the itch was coming from. So of course, here we need a diagnostic workup, and blood was taken, and there were no pathological findings in the blood count, also in the chemistry. So the renal and the hepatic parameters were in normal range. We did an ultrasound of the abdomen. There were no pathological findings. Also, a chest radiograph was normal. So we needed more diagnostics, and an MRI was then performed, a thoracic MRI. And what could be seen was an intramedullary lesion at the level of T6 and T8. And this lesion was compressing the nerves, so that there was a neuropathic itch in the abdomen. A biopsy was not taken to see, to understand better this lesion because of the risk involved with the surgery. So there was a watch and wait strategy that was adopted in this case. And the child came to us a few years later, so 2.5 years later, and she still had itch in the same area. The area was bigger, had increased in size. You can also see here that the child is scratching more because you see that the skin is lichenified. You see also some excoriations in the skin. And several treatments were tried to alleviate the symptoms, so several symptomatic treatments, because the lesion itself could not be surgically removed. And so the girl tried emollients, topical steroids, calcineurin inhibitors, capsaicin, also antihistamines, and all of this without effect. And then we gave naloxone, which is a mu-opioid receptor antagonist, and the mu-opioid receptors are also involved in processing the itch signal, and this alleviated somewhat the symptoms. So here you see a complex case where doing an extensive diagnostic workup was necessary in order to find the cause for the itch. Now, about the diagnostic workup itself, of course, the medical history is of great importance, and you need a general medical history, but also a specific history to understand the itch. And there are several things you should ask about the itch. So when did it start? Where did it start? And how did it develop with time? Is it just a pure itch, or are there other qualities like burning, stinging? How is the intensity of the itch? And here you can use validated scales to assess the intensity of itch. Then the daily course of the itch, are there fluctuations? Is it more in the evening, more during the day? Is it always present, or does it come in attacks? Are there any triggering or alleviating factors? How is the scratch behavior? Also, the onset of itch is important to correlate with new comorbidities or surgeries or new drugs that the patient is taking. It's also important to ask about the previous therapies and how successful they were, because this helps planning also the future therapies for the patients. And it's also important to ask about the burden. So if patients are burdened by it, if there are any signs of anxiety or depression, that you also should treat. So the medical history plays a central role in the diagnostic workup. And then depending on how the clinical classification, how the skin looks like, further diagnostic may be necessary. So in case of a skin condition, usually you can just diagnose by looking at the skin, but if it's unclear what kind of skin condition it is, then a biopsy for histology may be helpful, also for direct immunofluorescence if you suspect an autoimmune disease. Also some special lab work may be also indicated. If you have a patient with non-lesional skin, then the lab work is of great importance to rule out any internal medicine condition. Radiology may be also important to detect any tumor that may be causing the itch, or nerve impingement, then you would need an MRI. And of course, if patients have chronic scratch lesions, and the diagnostic workup is a bit more comprehensive. Here, a biopsy might be also useful to differentiate between lesions that are just purely coming from scratching, or from a primary dermatosis that is being masked by the scratching behavior. But also here, an internal medicine condition should be ruled out. Radiology may be also important in these patients. The guidelines recommend an initial lab screening for all patients, and the parameters that should be assessed are here listed. So it's a complete blood count, and the renal and hepatic parameters, also thyroid, ruling out diabetes, and ferritin is also important to assess. And depending on what you find in this lab work, and also on the medical history, you might need further investigations that are also stated in the guideline. The histology, of course, may be important to if you suspect a primary dermatose, or if you want to rule out scratch marks, scratch lesions from a primary skin condition. The direct immune fluorescence may also be important, especially in older patients, where you may suspect autoimmune conditions, especially a pemphigoid condition. Sometimes the bullous pemphigoid starts without the blisters, so you don't see them. You just see normal skin, or a bit of redness on the skin, and the diagnosis may be then confirmed with direct immunofluorescence. Also, a very interesting diagnostic procedure that we sometimes do if we suspect a neuropathic itch form is to count the intraepidermal nerve fibers. So these are fibers that cross the dermis into the epidermis, and you can count them. And in neuropathic itch conditions, they are often reduced. So this is a special diagnostic procedure where you mark the nerves with an external marker, the PGP 9.5, and then you can see them very well under microscope, and then you can count them. There are reference values that you can use to see if the number of nerves is normal or is reduced, and if it's reduced, that's a sign of a small fiber neuropathy pointing to a neuropathic itch form. Then the radiology may be very important to rule out malignancies. This is especially important in patients that have chronic itch, but not that long ago. So if they have it for less than 1 year, you should always consider a malignancy. If they have the chronic itch for several years, then it's very unlikely, because the tumors they keep growing, and then they will also have other symptoms. But if it's a chronic itch lasting for less than 1 year, you should consider a malignancy, and for that you need then the radiology or the medical imaging, and medical imaging is also useful to rule out neuropathic itch, especially in nerve compression syndromes. There are several patient-reported outcome measures that you can use to assess the patient, because itch has so many. There are many aspects of itch that can be assessed. The most important one is, of course, the itch intensity, where you can use a numerical rating scale or a visual analog scale. And what we also consider important and recommend for all patients is a measure of quality of life, either the DLQI, which is you can use if there is a skin condition present, But there are also itch-specific instruments to assess quality of life. That would be the case of the itch equal, and that we recommend to use for all patients at the first visit and also at the follow-up visits. There are many more instruments that can be used to assess other aspects of chronic itch, like for instance, how the sleep, anxiety, depression, stress scales, also therapy goals that the patients might have. So these can all be used, but what the guidelines recommend is to always use an instrument assessing the intensity of the symptom and the quality of life. And that's why I brought you also these scales. There are 3 scales that are mainly used to assess itch intensity: the visual analog scale, the verbal rating scale, which is a Likert scale assessing itch from no itch until to very severe itch, and the numerical rating scale from 0 to 10. And you can use either of these, but it's important that at every visit this is used so that you can also assess the progress of the patient. And it's also now validated what these numbers mean. So in the numerical rating scale and in the visual analog scale, so if they score 3 over 3, then they have at least moderate itch. Over 7, it's a severe itch. And our goal should always be that patients have at least a mild itch. And for the quality of life, there are also here the DLQI and the itch equal. The DLQI you can use for if patients have a skin condition, but if they have normal skin, it's not such a good instrument. Then you should use an itch-specific instrument, and the itch equal was validated for this patient population. Regarding the workup frequency, the guidelines recommend to repeat the diagnostic workup in selected cases. So if you have a patient where the cause of the itch remains unknown, you should repeat the diagnostic workup once a year. And this is because certain conditions, for instance, malignancies, may not be detected in their very early stages because they're too small, for instance, for the imaging to detect them. And that's why you should repeat the diagnostic workup, especially if you suspect a condition like that. And we know that certain tumors, especially hematological conditions, lymphomas, they are often the first symptom of chronic itch. So with that, now we come to the therapy. And there are some therapy principles that are important to discuss. And the most important thing is that every patient needs an individual therapeutic plan, and this is adapted on many things, on the cause of the itch, but also on factors that are inherent to the patient, so their age, their sex, their comorbidities, what medication they're taking. So this all needs to be taken into account when planning a therapy. And usually patients with chronic itch need a multimodal regimen. That means they need a combination of topical therapy with systemic agents. And they might also need a psychosomatic therapy if they are very impaired from their symptom, if they have anxiety, depression due to that. It's also helpful to have a psychosomatic therapy in addition to the antipruritic therapy. And there are general measures that you can recommend to your patients, and you can do it right away. You don't need to wait for the diagnostic workup. This should be recommended right away, and this includes the application of emollients because most patients with chronic itch have dry skin, trigger avoidance, and other measures that are simple and that can be recommended. The guideline recommends a stepwise approach in the therapy. So the first step is the recommendation of these general measures that we just discussed, and these may also include the recommendation of using antihistamines, so non-sedative antihistamines. Usually they are not effective against the itch because most of the itch forms are not, they do not respond to antihistamines. So the exception would be urticaria, which responds very well to antihistamines, but for instance, eczema does not really respond to antihistamines. Nevertheless, the guideline says you can recommend them up to 4-fold dose because these are very safe medications. and they might bring some benefit at this early stage. And this step 1 should be immediately started, and you should not wait for the diagnostic workup to be finished to start the therapy. Then you have the diagnostics workup, and if you find a cause, there are some symptomatic therapies that you can recommend to your patients that are known to help for certain causes. For instance, gabapentinoids are drugs that help very well against neuropathic itch. So, paroxetine, for instance, is a drug that has antipruritic effects for certain hematological conditions, and so on. And the guideline is very helpful in that, because for each itch form, it states the recommended drugs, and the evidence that we have for those. And sometimes the cause remains unknown, or patients do not respond to this second step of the therapy. Then the guideline recommends to use systemic agents that have the goal to interrupt the itch signal. So these are drugs that act on the peripheral and central nervous system, and thereby trying to reduce the itch signal. And these are gabapentinoids, like gabapentin or pregabalin, also antidepressants, and opioid receptor modulators. They are often helpful in reducing itch. And of course, if you have the possibility um, of having a clinical trial, that these are often the best drugs that patients can have. So if you have a clinical trial center near to your clinic where you can, with itch studies, then you can also recommend that. Regarding the general recommendations, I brought here this list of things to avoid, things to use, and this you can discuss with your patients. So of course, patients should avoid everything that promotes dry skin, because dry skin is also a factor that contributes to chronic itch. They should avoid irritating substances. Spicy food may also increase the itch. Emotional stress or physical stress may also increase the itch. And if they are allergic patients, also allergens may increase the itch, and they should try to avoid them as good as they can. You can recommend the use of mild soaps that are not so aggressive for the skin, showering with lukewarm water instead of very hot water that can also damage the skin. Airy clothing is sometimes also helpful. And probably the most important recommendation is the consequent use of emollients, because these are actually the only effective therapy to restore the skin barrier. And there are some emollients with additives against the itch, like urea or menthol or polydocanol, and this may also help reducing itch. And if patients are also developing mental disorders due to their itch, psychosomatic intervention can be helpful. And as a dermatologist, we are not really trained for that, but we can refer to colleagues that are specialized in this area, and can help the patients cope with their chronic itch. There are several topical therapy options. Emollients we have discussed. Topical corticosteroids are useful for inflammatory skin conditions, also to scratch lesions, but of course they should not be used for a long period of time due to the side effects, especially the skin atrophy. Calcineurin inhibitors are very safe. They can also be used in small children. They are only approved for atopic dermatitis, but they can be used for a longer period of time, and can also be recommended to patients with inflammatory skin conditions. Another drug that we don't have it in Europe, crisaborole, is not used in Europe. It's used in the US for atopic dermatitis. Is also an alternative that may be recommended. I'm not sure about India, if it's available there or not. Capsaicin is helpful for localized forms of neuropathic itch. I will show an example later. And this is available as a cream, but also as a high dose patch. And of course, topical local anesthetics can be also used. Usually they just reduce the itch for a short period of time, but they may also be helpful in the treatment of chronic itch. And here is a case of a patient with a condition called notalgia paresthetica, which is a neuropathic itch form at the back. So it's a localized neuropathic itch condition. And you can see on the left side that the skin is darker there. This is because the patient is rubbing for a long period of time, and then the skin gets thicker and darker. So this is secondary to skin manipulation. And in this case, she was treated with a high dose capsaicin patch, which you can see in the middle figure. And this is a patch that stays for 1 hour in the skin. It burns a lot, so capsaicin is in chili. So it really burns a lot, so patients should take a painkiller before. And after 1 hour, we remove the patch, and this burning sensation, it lasts for up to 1 or 2 days. But if the therapy is successful, the itch is then gone for several months, and you can repeat this therapy every 3 months. So it's a very elegant way of treating these localized forms of neuropathic itch, because then you avoid systemic medication. And the way it works, it's thought to be because the nerves get activated very extensively due to the high dose capsaicin, and they are depleted of the mediators. And also the small nerve endings are destroyed by capsaicin, and that's why we think that it induces a longer period of time without symptoms after the use. So now coming to the systemic therapies, there are several options that can be used in the treatment of chronic itch, and we have drugs that are immune modulating drugs or anti-inflammatory, like phototherapy, but also glucocorticosteroids. We don't recommend the use of systemic corticosteroids. We have also the classical immunosuppressive drugs like cyclosporin, methotrexate, azathioprine, and now the more modern targeted therapies, biologics, and also the small molecules JAK inhibitors that can be used to treat chronic itch. And then we also have drugs that work very differently. So they are anti-nociceptive drugs, like the gabapentinoids, the antidepressive drugs, and also the opioid receptor modulators. And here I bring you a case of a patient with chronic prurigo. So she has very severe chronic itch, and you can see by how the skin looks like that it's a very severe case with very intense itch and with a lot of scratch lesions all over the body. And this patient was otherwise healthy. She had an epilepsy, but otherwise she was healthy, and the laboratory workup was also unremarkable. And I brought you this case, this is a real case that we treated here in Berlin, and so that you can see what therapies that were performed. So she had several therapies over the span of 2 years that she was treated here with emollients, topical corticosteroids, phototherapy, and several systemic therapies, including antihistamines, gabapentinoids, antidepressants, cyclosporin, and even fosaprepitant, which is a neurokinin 1 receptor antagonist that's off-label for chronic itch, but may also help in selected cases. And she was several times, she stayed several times in hospitals. She went to several specialist consultations over 2 years. And with all these therapies, this is the result that was achieved. So there was in the upper body a very good improvement of the itch and of the lesion. So the patient did not have to scratch anymore in the upper body, and you can see how the back improved with the therapy. But in the legs, the itch was still strong, so that the patient still had to scratch, and you can see that there was only a very slight improvement in the lower extremities. And these was achieved with the therapies that we had previously. Now we have new treatment options in chronic itch not so long ago, and the first drug that was approved for prurigo was dupilumab, which is an antibody targeting IL-4. And here is a case report also a patient from Berlin, where you can see in the left clinical picture an extensive prurigo that healed after a few months using this antibody. And the clinical trial showed also very nice data with an improvement of the chronic itch and also of the skin lesions. Of course, when the itch improves, the patients do not have to scratch anymore, and then the lesions also improve gradually with time. And you could see here on the left, you see the improvement of itch measured by an improvement of 4 points in the numerical rating scale. On your right side, you see the improvement of the lesion. So IGA 0 or 1 means the patient has less than 5 lesions. And these are all patients that have hundreds or at least 20 lesions that to be included in the study, they have to have at least 20 lesions. And so you see that with dupilumab in the span of a few weeks, there is a vast improvement of the itch and also of the skin lesions. This was the first biologic, but then for prurigo, there is now a second one just approved a few months back, which is nemolizumab targeting IL-31, so interleukin-31, which is a very important mediator of itch. And also here, you see a very strong improvement of itch and a very rapid one. So the curve has a bit of a different dynamic compared to dupilumab, which with an improvement, a faster improvement of itch in the beginning. And also then the skin also improves because the patients don't have to scratch so much. So these are the two biologics that are approved for prurigo. And they are quite new for this indication. So before that, only the conventional therapies were available. In case of atopic dermatitis, there are more drugs available. We have 4 biologics and 3 JAK inhibitors. I just brought you this study because this is an interesting comparison, a head-to-head study between a JAK inhibitor, abrocitinib, and a biologic, dupilumab. And you see here in the diagram that patients being treated with the JAK inhibitor, this is the orange line, the high-dose JAK inhibitor, they have a very rapid improvement of itch. And patients with dupilumab, that's the green line, the itch also improves, but not so fast. But if you wait long enough, then these two curves will overlap, meaning that the same proportion of patients will achieve a significant improvement of itch with these two drugs. Just that JAK inhibitors are faster. Of course, the safety is different from these drugs, and dupilumab is a very safe drug, and you don't need any kind of lab monitoring. For the JAK inhibitors, you need to do lab monitoring. There are also safe drugs, but they do need more. They do need regular lab monitoring, and there are some complications that have been associated with JAK inhibitors that you need also to discuss with your patients. And now regarding a different form of itch, so nephrogenic itch from renal insufficiency, there is also a new drug approved. That's why I brought you also this study. And this is a very different drug. It's a kappa opioid receptor agonist, difelikefalin, and it's an IV drug that you can give to patients after the dialysis, and it reduces the itch associated with the renal insufficiency. And it's now approved, and it's also the first-line treatment for chronic itch arising from renal insufficiency, as recommended by the guidelines. So overall, there are several systemic therapy options that you can consider for chronic itch. You have antihistamines, gabapentinoids, antidepressants, opioid receptor modulators. You have the classical immunosuppressive drugs, and now you have the novel targeted therapies, biologics, and JAK inhibitors. And depending on the cause of chronic itch, they may help better or worse. But it's important to say that most of these drugs are off-label. They are not approved for chronic itch. The antihistamines are approved for chronic itch, and the biologics and JAK inhibitors are approved for some indications, namely atopic dermatitis and chronic prurigo. And there will be more coming because with a better understanding of the pathophysiology, there are more targets that are being identified in chronic itch. And there's a lot of studies going on, also with very different drugs. We just have 45 minutes, so I cannot really discuss them. But you can expect that in the coming years there will be more therapy options coming for the different forms of chronic itch, and this is important because then we can also have better therapies for our patients. So to sum up, chronic pruritus has a wide range of clinical manifestations and different possible etiologies. The clinical classification of chronic itch is very important because it informs the diagnostic and therapeutic approach. And usually patients need an extensive diagnostic workup, including blood tests and in selected cases, also skin biopsies, radiology, or other procedures. Regarding the therapy, their guidelines recommend a stepwise approach and either with anti-nociceptive or anti-inflammatory drugs. And we are seeing now a lot of development, a lot of pharmaceutical development with novel targeted therapies coming. And this is due to the fact that the pathophysiology is now better understood. And with that, I thank you for your attention. Here is our team photo. And if you want to learn more about our department and what we do, you can scan here the QR code. Thank you very much.
Well, thank you very much, Dr. Manuel Pereira. This was an extensive approach to the diagnosis and management of chronic pruritus, prurigo, and such a short time of just 45 minutes. It was very much knowledgeable, and we really thank you for that. And we have what 10-15 minutes for the audience questions, and then I can start with the first questions. Dr. Kunal, can you help me to questions? We can take up very rapidly. The first question is from Dr. Kriti. Any experience with managing chronic pruritus in chronic liver disease patients, especially those not responding to UDCA antihistaminics?
Yes, these are patients that are difficult to treat. Just about the symptomatic treatment of chronic itch, we have good experience with opioid receptor modulators, so with naloxone or naltrexone. So we have good experience with that. We also have good experience with gabapentinoids. Of course, you have to monitor the liver function for these drugs, but we have good experience with those drugs in these patients. But it's quite difficult to treat them.
Yeah. The next question is that what is the maximum duration that you give antihistaminics for? And because
Yeah.
most patients do relapse after discontinuation, so can you continue them for very long?
Yeah, well, that's an important question because antihistamines, they work well for urticaria, and for urticaria, you should give them as long as the patient needs them. So if you have a patient with chronic urticaria and he's controlled with the antihistamines, you can try to discontinue after a few months and see if the urticaria comes back or not. And if it comes back, then you can restart the antihistamines. For the other forms of chronic itch, for eczema, for prurigo, for also this internal medicine forms of itch, usually they don't work. So you can try it for a short period and see what a patient says, but usually they don't work because the itch from these conditions is not an histaminergic itch. These are different nerve fibers that process the itch. So usually they are not effective. There might be some placebo effect, but usually they don't work. If the patient says it's working, then you can just keep giving. So these are very safe drugs that can be given for a long period of time. So there are no issues there. If he tolerates well the drugs and if it's helping, then I usually leave them on the antihistamines. But usually they don't really work in most forms of chronic itch.
Okay. Michael, just a small request. Could you stop sharing your screen so that we can see you
Yes, sure, of course.
in a larger form?
I'm not used to Zoom, so I'm not sure how I stop. I will try to.
Yeah. Okay. Done.
Am I still sharing or is it?
Oh no, it stopped.
Stopped. Okay. Very good.
So the next question is about the from Dr. Debashis is the role of H2 blockers and leukotriene antagonist with H1 blocker. Any added effect?
In my opinion, there is not much added effect. So I don't use them actually at all.
Okay,
I
then
would not recommend them. The guidelines also do not really recommend them.
can capsaicin itself induce dermatitis?
Well, capsaicin, so if you apply it in high concentration, especially, you have a really red skin, so you have an irritation of the skin. But this goes away after a few hours or 1 or 2 days maximum. So in that sense, it induces a dermatitis, but this goes away. What helps is to give a cooling cream afterwards. That helps then with the patients, but it does induce an acute form of skin irritation.
So the next question is from Dr. Bhomik. What is the difference between the using aprocitinib compared to tofa or upadacitinib?
Yes.
Any data on it?
Well, here in Europe, we don't have tofacitinib for atopic dermatitis, so it's not approved for that. So we don't have experience with that, and I certainly don't have any experience with tofacitinib. Regarding abrocitinib and upadacitinib, they are both JAK1 inhibitors, and there are no head-to-head studies, so it's difficult to say if there is a difference. From my experience, I think they are both very effective drugs for eczema and also for the itch itself. And they are also comparable regarding the side effects. You might see a bit more acne with patients with upadacitinib, at least that's my subjective impression. Some patients might have headaches as well with both drugs, maybe a bit more with abro, but this is just from my own experience. There is no really comparative studies showing that, but both are in general safe and both are very effective. So they are comparable in my opinion. There is no reason to give one and not the other.
So I think a personal question from my side, and I think Dhaval sir, even you can ask a few set of questions that will help us out. Uh, uh, would you consider pruritus as one of the markers of disease activity in autoimmune rheumatic disease? So we see pruritus in patients with systemic sclerosis, and we also see pruritus in patients with Sjogren's, the Sika
Yeah.
feature, where the skin is dry. But in systemic sclerosis, it is very common and often quite troubling. So, how would you manage those? Would you increase the immunosuppression or just emollients and antihistamines would work?
Well, these are the difficult patients where you really need a multidisciplinary approach. And if you treat the itch symptomatically, you would not increase the immunosuppression right away. I would start with trying to control the symptom by itself. I don't think it's necessarily a marker of disease activity. Because you see patients with itch, but you also see patients with systemic sclerosis where itch is not a problem, and they may have also a very you know so the systemic sclerosis may also be quite advanced, and itch is not the major problem that they have. So I don't think it's a marker of disease activity, and and regarding immunosuppression, it's a question that the rheumatologist can better answer than I do. But you can try to target the itch with other approaches.
Okay,
The
good.
Praveen sir has raised the hand. I think he wants to add or ask something.
Dr. Praveen Hisare
Praveen
is
sir.
scientific chair for the conclave,
Yeah.
and I think he has.
Yes, thanks for a very comprehensive talk. Actually, it was excellent. My
Okay.
view was about we're not still used to using dupilumab in the chronic itch conditions, and my question was: do you actually wait for them to develop the typical prurigo nodularis like lesions before you embark on dupilumab, or do you have a algorithm apart from what the guidelines already state in terms of the timing of initiation of dupilumab injections?
Yes, that's a good question, and that's also depending on the local regulations. In Germany, we can start right away with the targeted therapy. So we usually don't wait so much. We just start with the biologics or the JAK inhibitors in case of AD or in case of prurigo with the biologics. In other countries here in Europe, they have to go through cyclosporin or another kind of systemic immunosuppressive drug before you use targeted therapy. So that very much depends on the local regulations. Regarding your questions, so if they have chronic itch on normal skin, we wouldn't wait until they develop the nodules. First of all, because not all of them develop the nodules due to scratching. Only predisposed patients develop them, and we don't really understand why some patients scratch and develop prurigo and others don't. We have a clinical trial for patients with chronic itch of unknown origin, so in normal skin, with dupilumab. So we enroll them in these trials, or we ask the insurance companies if they would pay the off-label use for this indication. So we don't wait. We prefer to treat as soon as possible.
And do you do a skin biopsy before starting them normally on dupilumab without the specific prurigo nodularis lesions to see if there is any degree of inflammatory infiltrate?
No, we don't. We just do a biopsy if we think that there might be a skin condition that we are missing. But if it's a normal skin, we don't do a skin biopsy.
Thanks.
Okay, so there's another question. Tofacitinib is only for atopic dermatitis or can be used for chronic pruritus of unknown origin?
Well, here we cannot use to any of those because it's not approved for other indications. So we cannot use tofacitinib for any indication in dermatology. Regarding the other JAK inhibitors, they are only approved for patients with atopic dermatitis.
There are two questions from Dr. Mudula. Any role of ondansetron in hepatic pruritus? And second, can we use dapsone in prurigo?
Well, we don't use dapsone in prurigo. I'm not sure if there is data on that. There might be. That's a good question. I don't know if there are case reports with dapsone. Maybe there are, because we use dapsone for a lot of stuff, but not for prurigo. So and with the therapies that we have now, I don't think that dapsone would play a role now in the therapeutic algorithm of chronic prurigo. And regarding ondansetron in hepatic pruritus, it is described. We tend to use other drugs, so it's not our first choice. But I know that there are case reports at least on that, so it might be tried. Usually, would the colleagues of it, so the internal medicine physicians would prescribe that. So we, as a dermatologist, we don't really prescribe ondansetron.
Yeah, then there's one more question regarding is skin biopsy recommended in patients with chronic prurigo with no skin lesions and no discernible cause to identify neuropathic cause?
Well, yeah. If you have normal skin, so non-lesional skin, there is no skin lesions, and you suspect a neuropathic itch form, then a skin biopsy can be helpful to assess the skin nerves. This is however, a diagnostic examination that's only done in a few laboratories. So it's a very specific examination, and it's also quite expensive. But you could do that, especially if the patient has not just itch, but also a burning or tingling or stinging. So this neuropathic characteristics, then it could be useful to detect a small fiber neuropathy. We do that often, for instance, in diabetic patients who have itch, to see if the small fiber neuropathy could be a factor. So sometimes we do it, but in very selected cases. Yes. But it can be helpful, yes.
And I think the last question is, in your case of the young child with umbilical itch, what made you think of doing a spine MRI?
Yes, the fact that it was localized was pointing out to some local factor causing the itch, because she only had itch in the abdomen. This is one thing, and what's also typical for neuropathic itch is that it is alleviated by cold, and the child was always laying down on the cold floor, so that was also an indication that it could be something neuropathic, and And that's why we thought there could be some compression of any kind, and that you can detect the best with MRI. So you wouldn't see that with an ultrasound. So these were the two clues from the medical history that led us to do the MRI.
Okay. And any
So
more?
the last question from myself, Kunal, Dr. Manuel, is really there is a psychological cause for the chronic pruritus. Wouldn't you like to go deeper and deeper to find the cause, rather just to label them as this is a psychological cause? I mean,
Yeah.
what's your experience in such a long
Yes.
your career?
That's a good question and a difficult question. The problem we see is that many patients, they are, often physicians tend to say this is a psychological form of itch, so it's a psychosomatic cause, and they don't do the proper workup. So I don't really believe very much in a psychological form of itch. It's an exclusion diagnosis,
Yeah.
and even if you don't find anything, it's I wouldn't classify them automatically as having a psychological cause for their itch. You can diagnose a somatoform itch if there is a clear correlation with the symptom begin and some life event, for instance, the death in the family or some kind of traumatic event, and then the itch starts at that period of time, and you find no other cause. Then I think you can really diagnose a somatoform of itch. But otherwise, I would always classify as unknown origin if you don't find anything else, because there is a lot of stigma with this diagnosis of somatoform itch, and for patients, it's also not easy to receive that diagnosis. So it's if you give this diagnosis, you should really be sure of that, and you should also, in my opinion, you should also have a psychiatrist helping with this diagnosis. Because there's a lot of stigma, and many patients, they just are given this diagnosis although no workup was done, and they have for instance, just an atopy or something. And so yeah, but it's good that you brought that up, because this is a very as a topic that we deal with every day almost.
So I think
Well,
yeah.
should we conclude, Kunal? I mean,
Yes,
that was
we
an
can.
excellent. I hand over to you. Thank you very much, Dr. Manuel Pereira.
Thank you for having me.
Thank you so much, Manuel, and it was wonderful. This was a very simply presented, lucid talk. I think our confusions regarding we'll itch less when we see a chronic itch now. And you did talk about few recent guidelines. If you would be a gentleman enough to send us those, I think we can share it in the group, and people will read it the next time they see a patient with chronic pruritus.
Yes, I can send you the European guideline. This came out just like 2 weeks ago. I will send you the new version.
Thank you. Thank you so much. And
Thank you.
I think we end today's session with this. The next session is on this Friday, and I hope to see all of you again there.
Thank you.
Thank you very much. Thank you.
Thank you. Thank you.
Thank you.
Good evening.
Thank you. Bye. Good evening.
Bye bye.